I'm Jim Garrison, and I want to welcome you to day 207 of Humanity Rising. I want to welcome you in the spirit of the rising springtime all around us as we approach in 2 days the spring equinox in the north and the fall equinox in the southern hemisphere. The light and dark dimensions of our world are changing and coming to that exquisite equilibrium of balance in just about 48 hours. We are grateful for being alive today on planet Earth, even though we're in the midst of this extraordinary pandemic. And I want to start today, as we always do, with just centering ourselves, feeling your body, taking a few deep breaths, closing your eyes, and placing your attention on your heart. Listen to your heartbeat for about 60, 90 seconds in a spirit of deep gratitude and thanksgiving that you're alive. We're alive at this extraordinary moment in the human journey. Thank you, everyone. And now, with an open heart and a heart full of gratitude for each and every one of you that have joined our session today, I want to note that even as the light and dark dimensions on our little planet circling our sun is reaching a perfect equilibrium, the human race is more out of equilibrium than we've ever been in the history of our kind. There is ecological turbulence. There is political and economic and technical dynamism that is upending traditions, shape-shifting economies. And we're experiencing everything from extreme weather events to massive migrations due to water shortages. And over the last year, a pandemic that has had a catastrophic effect on our world. We didn't expect the pandemic. It was one of those black swan events, and a year later, we're still in the pandemic. And people are experiencing pandemic fatigue, and I would say pandemic exhaustion. We just want it to be over because we want to go outside and be generative and full of life given the rising tide of spring. And we can't do that. So even though we're done with the pandemic is not done with us. And so we're in this excruciating psychological, emotional, physical situation. The vaccines are rolling out, but there are complications. And in Europe, with the AstraZeneca vaccination, it's been stopped because of all kinds of effects. In the United States, it's rolling out, but there is consternation and bureaucratic snafus of all kinds. Many countries around the world don't have access to vaccinations at all. And so the issue that we're going to be delving into today, as we have over a number of sessions, is the issue of public health. Public health in a time of COVID. And it's being convened by Nordic Health 2030 and the European Health Futures Forum. And we're in our fourth of 5 sessions delving into the multidimensionality of public health. So I want to now turn our program over to Lars Munter, who has been working with Nordic Health 2030 and has been a co-convener with David Somekh of the European Health Futures Forum of these 5 sessions. Lars, welcome.
Thank you very much, Jim. We're happy to be back today discussing, of course, digital health. David is arriving shortly too. The wonders and joys of international collaboration is, of course, that time zones differ and thus also daylight savings as well.
Yes, we're being struck by daylight savings time today.
Yeah. But going back a bit, 3 weeks ago, when we held the third of our series of 5, we had a session on ecosystems that some of you that are here today might remember, where we stressed the interconnection of health with the environment, stressing especially the notion of the circular economy, the economy of well-being, the idea of having a financial system that focuses on health and well-being as the center and core of developing a society based on health literacy. But also, of course, taking into account issues outside the healthcare system itself or the health department per se, social solidarity, education, and so on. This was showcased by senior officials from the Scottish and New Zealand governments, where they've already begun this work. And today we have a partner from Finland too, one of the recent additions to that team of future thinking governments across the world. And finally, we last time in our series of 5, we presented the EHFF futures vision for that. But today we turn to a different kind of ecosystem that's evolving quite rapidly across the world. Some have more advanced, I guess, stages of development than others, but it's of course the digital ecosystem. Another type of life stream that flows through all of our healthcare systems and powers it. Sometimes, it challenges us because we have, insufficient ways of understanding how to use all those data and to use them for good. My good colleague, David, he pointed out an example to me that, and of course, being an experienced healthcare professional that he is, he remembered when he started in university that he had to turn to use the computer. He was able to actually express this as a singularity. There was only one in the university, and he had to use, of course, these key cards that those of us old enough, I've never seen them in action. He had, but none below the age of I guess 40 would even know that they existed. Yet every one of us today have a very personal relation to a supercomputer. We hold it often in our pocket. So it's a massive change from then to now. Today we'll consider some examples of the impact of this technology, the impact of the data that we use, and reflect upon this from a system, from a productivity and efficiency point of view, but also, of course, from a more humane point of view, how it affects us as individuals and the interrelation between us and the systems that we work with to deliver health to ourselves and our citizens. But first, let me introduce Jana Sinipuro of the Sitra Fund in Finland. Jana, what a wonderful thing to have collaborators like you. And thank you very much for being here. And thank you for allowing me to be here as well. And Jana, if you will, please tell us a bit more about your ideas and thoughts and work within this digital age.
Okay, thank you for the invitation, and I have to say thank you, Jim, for the very refreshing start and also very elevating start for this event. And while I'm trying to share my slides, I tell a little bit about myself. Yeah, that should be okay now. I think so. Yes? Well.
Yeah, you're good.
Yes, it works fine.
Good. Yeah. So it's not so easy because I've been working with data and technology like 20 years and almost already, and maybe most of the years within healthcare, but making Zoom work or data, this Teams work, it's not easy task. But anyway, yes, I think being a long time along with digital tools, data and technology, working in the US-based company called SAS Institute with data and analytics, I think it's very interesting moments we are living with the digitalization and our common understanding for the importance of data and digitalization has increased quite a lot in the recent years. Maybe it's because of the big tech and all those phenomena we are seeing, but also all the benefits we are getting from data. So saying that data saves lives is very true. And just yesterday, I heard a good example just coming to this COVID vaccination programs. One statement was that the reason why Israel is progressing so well in their vaccination programs is that it's actually a data business. Of course, there's the programs where you need to evaluate your outcomes with your treatments, your medical trials, and you need data for that. So basically, I think we are more and more facing that we cannot talk about services and we cannot talk about healthcare provision without thinking of data and without thinking of balancing the interest of different stakeholders and thinking who provides the trusted services. So it's not just technology, it's also attitude, skills, and expertise on using data. And that's pretty much the topic for my short intro. I work as a project director in a project called Fair Data Economy, which is a European approach to data economy, enriching data, using data for business benefits and building data-based ecosystems. We think that we need to challenge the existing way of data economy, either company-based model or government-based model like the Chinese model, and maybe create more human-centric model as an alternative to these existing business models for data economy. So that's my topic today, and I'm happy if you challenge me and think that this is mission impossible, that we are the ways we use digital tools, can we alter those, or do we just need to use them as we are used to use them? But before going further, I think there are many ways, and what's crucial if we want to use digital tools for our well-being and provision of healthcare services, remote consultation and so forth, we need to have a trust-based infrastructures, and it's not enough with privacy by design or security by design principles when designing technical infrastructure. It's also very much data-related topics, how skilled people are handling the data, how literate patients and users are using data for their own good, interpreting data and interpreting statistics, findings from data. So it's if we want to create this trust infrastructure, I think it's not just data and technology, it's not just guidelines, it's also governance models and empowering people to participate in the decision making based on the relevant data for them. So that's why I think that we need to broaden the discussion when talking about ecosystems, when talking about usage of data, how we create these trustworthy ecosystems within healthcare for use of digital tools. And this is pretty much evident that technology is becoming embedded in everything. It's a social media accounts are getting more and more patient data, because communities are looking for comfort within Facebook. So these private platforms are getting more and more information, personal information about our well-being. And it's very hard to integrate and get control of all that personal data we are storing in different devices and on different platforms. So that's the reason why I think that there should be more like overall awareness about how our data is being used and how we can ourselves benefit from the data. In last years, it's been interesting to see how these non-traditional players, how big tech is entering the healthcare field, and maybe we are seeing a little bit like a change here as well, because of course me coming from the Europe and working quite closely with the European Commission on the GDPR enabled data sharing and the regulations Europe is putting for the handling of data, and these different regulative frameworks Europe is working on, they all maybe push companies to rethink about their habits of using personal data, healthcare data included. So there are many initiatives currently happening in Europe working for these frameworks and legal frameworks and also rule-based frameworks for data sharing. But then it's interesting also that I think the traditional healthcare providers can learn a lot from these digital giants, the way they deliver services, the way they automate processes. But I'm thinking that maybe both parties can learn something from each other. So the recent news, Amazon that started their digital services for their own personnel is now acquiring more physical premises also for service provision. So it's very interesting to see where we go with this recent developments, and maybe also for traditional service vendors, what can we learn from these digital processes and how we can improve our lives by using those digital tools. That's a very topical question for the sustainability of the systems. But at the same time, if we are moving all the services, and like now, virtual world, how do you transfer the empathy you are able to provide in your traditional meetings and consultations, patient consultations? I think there maybe we can learn from those how other industries are doing, and still how we create this holistic view about the person life event with a permit from individual, with a consent from individual. We need to be able to understand the whole life situation if we want to tailor the digital services to fit to the situation person is experiencing. So it's very crucial that how can we create this holistic, from different apps and devices, services, how we create this holistic view of the needed services, and how we transfer the empathy we are able to transmit when meeting in physical world, how we transmit it to digital age. I think this is a big question when thinking about well-being services. This is my approach to what we are doing, saying that we need to, I think we need to alternatives. We need to have this human-centric agenda, even when it comes to the data and building new services based on data. Data ethics is a topic we need to consider if we want to build good services for digital healthcare and well-being. So I think one tricky question is how to balance the interests of different stakeholders, like privacy concerns from individuals and persons donating their personal data for research, stakeholders like companies, how they can benefit and build new services based on data sharing, and then end users' rights. There are so many different stakeholders. There's concerns. And of course there's a business side as well. So how do we balance these different needs? That's also very crucial for the sustainable future of digital health. One concept that I like very much is handling data as an equity. There needs to be data strategies in place. There needs to be like strategic purpose on why you gather data. It used to be like technology enabled us to gather all possible data about individuals and events, big data being there for ages. But maybe we should gather a little bit less and more relevant data. So that's why I think that this accountability and data gathering and treating data as an asset will be the future if we want to create more sustainable services. So having clearly stated purposes, why you gather data, how you use it, for what kind of service provision, maybe that's a good concept and something that all companies should think if they want to maintain the trust from the individuals. So, but there's also the second meaning in handling data as an equity, this fairness of value realization. So transparency, accountability, equal access to data. I think it's a very interesting notion. Sometimes we refer to data as a water, sometimes as a soil, but data as an equity is a very interesting metaphor for me because it shows the importance of data, but also that it should have more equal, we should have more equal access to data. Rules, we need to have common code of conduct if you want to create personalized services using personalized data coming from individuals. I think we need to have agreed rules or code of conduct of how we use sensitive data. These data sharing ecosystems should have common rules if they are asking for each other's data and if they are building new services based on sharing data. So it's not just regulation. I hope that companies voluntarily improve their processes in data governance and increase transparency when handling data. But of course, those companies who are leading, who are very transparent and respect the individual rights in the use of data, they need to be identifiable. So we need to have some kind of labels maybe for fair data companies that are using data in a fair and equal way, so that consumers can tell that there's a difference. This is the unethical use of data. These are the ethical companies, and maybe start preferring those companies that respect privacy rights and respect individual rights when it comes to personal data. And I hope that new industries like digital tech giants have lots to learn from traditional industries, but vice versa, traditional industries and service provision has a lot to learn about smoothness in digital processes. But we need to balance, and we need to create more choices and not just be happy with the existing ways of delivering services. This is some paper we made earlier, the thinking how we ensure that there will be trustworthy health data ecosystems in the future. What's the role of individuals? This paper is very much based on the work we did in the Nordic Health 2030 project. Building from there, having this my data thinking in the core, and explaining what companies should do, how the policymakers should think about data sharing. And I hope that you will maybe have time to have a short look at this paper. That the link is in the presentation, and I'm happy to continue discussions. So I think the big question is the value of handshake. Earlier, the medical doctor, when you went to the doctor and met the doctor, one handshake was a very good diagnostic tool. How we transfer that knowledge, how we do the same trick in the digital age. Of course, there's more and more data, it's more and more scattered, it's more and more detailed data about your conditions, but how we pool that data and how we make it relevant and how we use it in an emphatic way, that's a top question if you want to create those sustainable digital services for well-being and health. Yes, thank you.
Wonderful ideas, Jana, on both the value of a handshake and maybe also the value of human connection and certainly dancing. I have yet to learn the Finnish tango or any type of tango, to be honest. But of course, there's hope still. I think we now can turn to Kieran Walsh to add another perspective, and then feel free in the chat to ask some questions. We'll follow up later. Some comments and perhaps a bit of a handshake or a comment or even a dance for Jana. But Kieran Walsh of the BMJ, also a somewhat well-known institution in the celestial system when it comes to medical information and training of healthcare professionals. Kieran, enlighten us, please, about your work in the digital health area.
Hi, Lars. Thanks very much for the invite. It's great to join you all. And I'm going to talk about patients with COVID-19 and comorbidities in the acute setting and the role of digital clinical support. I'm clinical director at BMJ. And our clinical decision support tool is BMJ Best Practice. BMJ is best known for the journal, which of course is our flagship journal, bmj.com, or the BMJ, where we do a range of different things. And one of the other things that we do is BMJ Best Practice, which offers clinical decision support at the point of care aimed at healthcare professionals, structured around the patient consultation. And it offers knowledge that's evidence-based, continually updated, practical. It's a knowledge resource where you can get answers to your clinical questions. And of course, it's all digital. But you don't just get any answer. What you get is an answer that's important to you. And what we've discovered in this digital world is what the users want is these things. They want an answer quickly, within seconds. They want an answer that's actionable and practical. They want to be able to access it anywhere, anytime, which means on a desktop, on a laptop, on a mobile, on an app, online or offline, increasingly integrated into other systems that they use, such as electronic healthcare records. And of course, they want content, excuse me, they want content that's continually updated and also evidence-based. And yet, there's a problem with evidence-based medicine. And that's a problem that evidence-based medicine is built around single diseases. And indeed, clinical decision support is built around single diseases and not multimorbidities. And just to be explicit, comorbidities means patients have more than one illness. And this has been a problem before COVID-19, during the COVID-19 pandemic, and will continue on afterwards. And whatever digital system we use, and we will use digital systems, which will be relying on data, the whole purpose of the systems and the data is then to help with the management, diagnosis, and management of patients. And yet we need clinical guidelines that will help us with the management of patients. Yet currently that's not the case because the guidelines are all built around single diseases. So this is a quote from Chris Whitty, who's the Chief Medical Officer of England, about 14 months ago, in an editorial in the BMJ in January 2020. And he said, the training from medical school onwards, clinical teams and clinical guidelines all tend to be organized along single disease or single organ lines. And this was written before he became a household name in the UK because of the COVID pandemic. So let's look at this issue of comorbidities in the acute setting, in the hospital setting. Most patients in the acute setting have more than one medical condition, but clinical resources only focus on single conditions, which is an important statement. And when comorbidities aren't taken into account, patients get suboptimal care, worse clinical outcomes, longer lengths of stay, with associated increased costs. There's more. 1 in 3 adults suffers from multiple chronic conditions. It's not just a UK problem or even a European problem. I've given talks like this in countries as diverse as Canada, Middle East, Pakistan, India. They all have problems with the multimorbidity. In the UK, 1 in 3 adults admitted to hospital as an emergency have 5 or more conditions, a remarkable statistic. People with multimorbidity have poorer functional status, quality of life, higher uses of care, higher mortality, tend to be poorer, all of which poses a major problem for health systems. But resources for healthcare professionals, including digital resources, including up to now our own resources, only focus on single conditions. And so about a bit over 12 months ago now, we launched a new tool, the BMJ Best Practice Comorbidities tool, to support healthcare professionals in providing holistic care, and so that they could add a patient's comorbidities to an existing management plan of a single condition, and so get a tailored holistic plan. And we launched it just before the COVID pandemic. And then, of course, we quickly realized we would have to add it to our resource on COVID as well, because it came clear that patients with COVID who had comorbidities were particularly badly affected and ended up in hospital and ended up in the intensive care unit. And since its launch, which is about 12 months ago, or a bit more than 12 months ago, it was launched in beta form. We've had a massive amount of usage and a massive amount of feedback and evidence that there's a real clear need for a resource like this. The idea is that you have a patient with an acute illness, maybe COVID-19, and you can add one or more of these non-communicable disease comorbidities to the patient's management plan, and so get a tailored plan. Importantly, it includes mental health comorbidities, because of all the problems with comorbidities, mental health ones are possibly the most neglected. And what we've found is that you get an exponential number of potential combinations of acute diseases and comorbidities. And also what we found with COVID-19 is that patients with comorbidities are higher risk of hospitalization and admission to intensive care, that they need tailored and holistic care, and also that this is a rapidly changing scientific landscape. So our topic on COVID-19 now is over 1,000 references. If you look up the digital resource PubMed, you'll find several thousand, well over 10,000 references on COVID-19 already. It's impossible for healthcare professionals to keep up. They need digital resources as well as data so that they have real-time access to the most current and the most evidence-based and reliable guidance to help them achieve better care. This has always been the case, but the COVID pandemic and the digital revolution has made this even more explicit and clear than it has been in the past. And so I think this is my last slide. You asked us to keep to 7 minutes, which I'm going to try and keep to as closely as possible. This digital resource, BMJ Best Practice Comorbidities, it's aimed at healthcare professionals, and its purpose is as follows: to improve the quality of care, ensure patient safety, drive patient-centered care, and save costs and drive quality improvement, which is, like, in fairness, everything else everyone else is trying to do. What makes us different? Well, what makes it different is that we have here a digital clinical tool, but that deals with real-world patients with multiple real-world diseases. And it's trying to do a difficult thing, which is to get doctors and other healthcare professionals to stop and think, and indeed make a strategic step in evidence-based medicine and digital clinical decision support, moving from academe to the coalface, from fragmentation to high quality and holistic care, and from single diseases to comorbidities. Thank you very much. I'm going to now stop sharing my screen, and I'm happy to answer any questions you might have now, or if you wanted to wait to the end, happy to answer them.
Let's wait a little bit, Kieran, but thank you very much for that rapid rush through a very, very interesting topic. So we've heard something about the issues about data safety, then we've seen a very real application of digital to patient care. And I want to move straight on. We'll try and get some questions through the chat and also some discussion after the next presentation, maybe, which will be, I'd like to introduce Mike Buick, who was formerly Deputy Medical Director of NHS England. And Mike has a particular interest currently in the whole issue of digital literacy, without which neither physicians, healthcare professionals, or patients can adequately use this amazing resource. So Mike, over to you.
Good afternoon, David. We finally got here. Thank you. You've had a harassing afternoon by the sounds of it. Never mind. Anyway, I think that my interest in this comes from work I'm doing at the moment, trying to support people in understanding digital health systems a little more. And one of the things that we've come up against is the fact that people are at different places along the journey of understanding digital literacy. I think we all know what we mean by digital literacy. We sort of know it, but there are definitions out there. And the one I'm using at the moment is the ability to use information and communication technologies to find, evaluate, create, and communicate information requiring both cognitive and technical skills. When you start to digest that and then break it down, of course, there's a whole lot of issues that surround it, and I'll cover some of those today. First thing to say, I've been just seeing the end of Kieran's presentation. I'm sorry, couldn't get back earlier to see early bits. We are, of course, dealing with a diverse community with different experiences, often, as you've just pointed out, Kieran, with multimorbidities as well, which impose barriers. Those cultural issues are forever present. And people will have different resources in accessing healthcare. And staff will have different resources as well. Not all providers are along the journey of digital health as much as others. And perhaps where we can use the lessons of the pandemic, where communication processes have increasingly been dependent on digital platforms and non-contact type experiences, we should raise the bar of expectation in our understanding of what a standard should look like in digital health, and particularly around digital literacy. This, of course, it has to be backed up by making sure that the system is safe. Pre-COVID, of course, there was already a march of care towards digital services and delivering new technologies, but policymakers were a bit perplexed because, of course, there is a myriad of governance arrangements and the GDPR issue, etc., which made many hesitant to use this as a primary force, a primary communication source for patients and other users. I think some of that fear has been eradicated in the last year, but again, it will be piecemeal. There'll be areas where there's confidence in using digital systems and confidence that people are getting value from them, and others where it's not. But do we know if they work? Are both service users and providers equipped to deliver and use digital technologies fairly? I'm not so sure they are. We lack the evidence from this. But sometimes we can look to other sectors to see whether the change to digital or the change to non-face-to-face type work has resulted in any problems. And I'll give you the education system. In the UK, most schools have either gone online or are using other formats that are non-classroom based. And we do know that that has not been delivered equitably. And probably it has enhanced some of the known inequalities that we had before in that sector. So we must expect the same, I think, in health services until we've answered some of the following questions, I think. And those questions to me are, is there evidence of equity of access? And if not, how might this be mitigated? I think that's a primary question before you start to roll out digital health tools to partake in a system as a normal system. Have we made sure that we're doing as much as we can to make it equitable? Are there commonly agreed standards in delivering the care this way? And there are available training programs to make sure that everybody is cognizant of the needs of a digital system. I don't think we're at that point yet, and I'll come back to that later. Is it acceptable in all cultural and ethnic groups? And if not, how do we adapt it to make sure they're not excluded? And in the UK, I think that is a really big issue. We've seen it around the vaccination program. I'm sure we're going to see it around the uptake of digital health systems. And also the resource issue, what investment is required and how do we make sure that's equitably shared? Large providers of healthcare tend to get things first. If you look at the rollout of major integrated management systems within hospital, integrated communication systems, they tend to be in the much larger trusts that have the financial clout to do so. How can we make sure that that's across the piece? And how, with all of these in mind, do we prevent accentuating inequalities? I think it's 50 or maybe 60 years now since Tudor Hart's paper on these sort of health gaps, and we've had every report, every 10 years or so, we get a major report demonstrating that those inequalities have hardly been narrowed in the treatment of disease. And we may well find that if we don't do this correctly, we'll end up with yet more inequalities again and a further widening. In the UK, there has been some work on this, and I think it's important to acknowledge that the NHS and the Department of Health and the government in general has looked to try and find ways to improve digital literacy through both health education. England's report written by Eric Topol and the original VACTA report, which looked at how you might implement digital systems and how long it would take to do so. These reports predated the pandemic, but they describe some of the requirements that complex health systems need to address in the development of the workforce and how it interacts with patients and carers. Also in England, we're about to go through a major legislative change. Again, this must be the 5th of my working career, and the 3rd certainly since I've been in health management. The broad aim is to deliver integrated care with a focus on the patient at the centre of that care pathway, and that is laudable and something most people on this call will have been trying to strive for years. But it's without an integrated IT and a digitally literate user, we will struggle to implement it effectively. So we must concentrate on the digital agenda. The barriers to this, in my view, are inevitably a resource one, but as importantly, cultural norms. The wider use of digital technologies in health, when patients have full access to their records, may challenge some professional views and behaviours. The pandemic has improved the relationships, but a digitally delivered care package, for the example for a long-term condition, which Kieran has just been alluding to, will require a far more mature and equal relationship between provider and user. It's that partnership that we've not yet developed in this. In the last few months, I've interviewed over 50 people, probably nearer 100 now, in depth, looking at their experience of the COVID pandemic. And the two issues that have come out there predominant for me are the reliance on teamwork and communication. And the second, the use of digital technologies to deliver healthcare at distance when it's been unsafe to do so otherwise. So the time is right for this mixed economy of care. All, however, we're concerned about exacerbating what I've discussed before, which are the health inequalities and how we don't produce another set of left behinds. The NHS is at the moment grappling with this and is gathering the evidence to see whether we can do this better. But perhaps what we need is an external, less partisan view of how health services and other public services are running through an ethical lens. It's very easy just to go down the organizational process route or some of the outcomes route, but actually we need to look at the ethics of this in as much detail and see whether this is the right approach. We shouldn't just be taking it on for the sake of it. We should have proven evidence that it's both acceptable, accessible, and in the end improves or at least does not harm. I'm an enthusiast for expanding the digital health offer, but it must be done so for all and as part of a wider offer of healthcare. And some of that is about the democratization of health and getting away from our reliance on large providers and moving to a more community-based approach. To do this, health and care systems must take a proactive approach in firstly promoting digital health systems, but secondly, offering support for service users to use them effectively, and lastly, to ensure that the workforce and workplace are ready to deliver a digitally enhanced service. While national regulators can set standards, it's up to the educationalists, providers of services, and the local leadership to enable this process. COVID-19 experiences demonstrated how quick wins can be implemented, and other countries outside the UK are ahead of us in many ways in looking at how we use digital systems and encouraging digital health literacy. In the world of Google, Amazon, and social media, the expectation is of a significant digitalization of health and care systems. To some extent, the population is ahead of us. That ability to upscale and upgrade digital health, but we must take the citizen with us. Thank you very much.
Mike, thanks very much indeed. That was really a tour de force in terms of looking at what the challenges are about digital literacy. I think if I can just check with Lars, I think probably we should ask Anders next to join us.
Indeed, Anders.
Hello to all.
Presenting, yeah, we have Anders with us here, a voice from the north as well. Presenting a powerful example of how to make this work in action, the Nordic Interoperability Project. Please, Anders.
Yeah, I'll touch into that. Let me know if you see my screen.
Yep, you're good.
Yes, we do.
Perfect. My name is Anders Hansen. I'm normally operating out of Oslo, but in a COVID-free world, I would probably be traveling across the Nordics, working on making cross-border patient and data mobility the Nordic reality. Heading then this project called the Nordic Interoperability Project. And I will tell you more about that. But for this presentation, I've said that with your life at risk when you cross the border, when your health data stays at home. And that is the current situation when it comes to then cross-national border initiatives. when it comes to the availability and accessibility of health data, we have built a system where we have trusted the healthcare system to take care of the data for us. And it is more or less locked into the healthcare system in such a way that you and I can normally not access the data that we want to have in a local environment, which is then the local interoperability challenges, but also when it comes to crossing national borders. And for every one of us who is working within the healthcare system, it's quite easy to understand why it is so, because of privacy, because of sensitive data, all of that. But if we look at a patient, and this is the starting patient of this project, Clara, who is actually living in Stockholm, she is living a very normal life like everyone else. But the difference with her compared to me and a lot of others is that she is a chronic patient. She has diabetes type 1. And she's living with that and having that condition as a part of her everyday life. And when you and I can pick up a passport and a visa card in normal settings without the COVID, and we could just go away and to abroad for the weekend without much more planning than that, just a visa card and the passport, Clara could do the same. But since she is a chronic patient, she would have to plan and plan again to make sure that she has everything she needs when it comes to extra medication, medical equipment, or her necessary patient data, just in case that something should happen. And the reason for this is that when she crosses the borders, her medical history does not follow. So when we started this project and we interviewed Clara and have had close contact with her, at the age of 17, when we started the project, we talked about traveling with her. And she said that when she was going abroad for trading purposes or for holidays or whatever, if she got ill in another country, she would rather try to get back home to Stockholm than to try to be treated where she was. And the reason for that was that she said, I don't just need a doctor, I need a doctor that knows me. So her problem was very obvious when it came to the missing piece of sharing data, health data. And when we live within the bubble of healthcare, we all understand why it is so difficult to share data, because we have a lot of given sayings on why it has to be like this. But we are not just patients, we are also citizens. And in a citizen's world, we already know that data is being shared, also data that we consider to be sensitive. So when I travel, my bank data is available at any mini bank when I'm traveling. If I check my account before leaving Oslo, I can then recheck my account in Barcelona. And in my world, that is sensitive data. My travel information is also available both at the airport in Oslo and also in the airport in Barcelona. It's also sensitive data to kind of give away where I am at a given time. And the reason for that data being able to be shared is because of interoperability based on international data standards. But when it comes to health data, then the data is not available at all because we haven't moved into this interoperability level. And this is something that has to change, and that is the project that I'm leading, trying to at least put on the agenda in such a way that the discussions could lead us and move us forward into a world where we can travel and have the data available. And that is a highly ambitious goal of a project. And the only reason that we can say that we want to do this is because the Nordic Council of Ministers, the ministers of the 5 countries in the Nordics, have decided already in 2018 that by 2030, the Nordic region should be the most integrated health region in the world. And they have even made a film that is visible and available at YouTube, where they have their future patient called Sophia, who is actually then in that film traveling across the Nordics and having her health data available for care process or for research and innovation purposes. So this goal is not set by us, it is set by the Nordic Council of Ministers. We are only in this project trying to push the agenda and push the envelope on this topic. Now, to fill this vision of 2030 into more depth, it was developed a report called the Nordic Health 2030 report, and I urge everyone to read it because there's a lot of good information there. But to highlight the most important is that it points towards the fact that the Nordic healthcare system is not sustainable. And the reason for that is that we are spending approximately 11% of GDP on traditional healthcare, or what we could define as sick care, because that is money being invested into the system when you have been defined as a patient, while we are only spending 0.3% of GDP on preventative care to keep you and I healthy and well. So the report is pointing toward a more balanced situation, so hence the 5-5 aspiration. And to make that happen, the report is pointing towards 3 areas. We need a new social contract with the individual. So you and I have to be more involved, not only in our care, but also in our well-being and to stay healthy. We need to have new ways of sharing data. And we also need new business models that is also rewarding preventative care. And in that report, there's a very balanced, nice picture that I'm showing at the bottom here, where we have the individual on the one side, this healthcare system on the other side, and the data flowing very nicely back and forth between those two. That is the 2030 perspective. In 2021, we know that the individual is more or less not involved in their own healthcare situation. So in this project, we have then initiated 3 areas where we could try to push the envelope and push the agenda. And one of them being to see if we could take benefit of the many data lakes of quality healthcare data in the Nordics and connect them together to what could be a Nordic patient data lake. But that would only be data already existing in the system. It wouldn't address the individual collected data. So for that reason, we have also taken the initiative to what we have called a Nordic digital health and medication platform, inspired by what they have done at NHS and in the UK, where they have in place an accreditation system and activation system for digital health solutions. I will shortly touch upon that in a minute. And then the third area where we are working is to make this data available for Clara or for Alva or any future patients in what could be a Nordic Health passport, a digital solution where you and I will be the bearer of our own healthcare information. And just to address this digital health aspect that is the topic for today's theme, is that yes, the answer to this question is definitely digital health and health apps are definitely the future. And there's a multitude of opportunities for you and I to access. And there's over 5 million downloads per day of healthcare applications. The challenge is just that, at least in the Nordics, there's no guidance to help you and I to separate the good from the not so goods. So you and I are being pushed to Google Play or Apple App Store to find whatever we think is looking nice, but there's no quality assurance behind. What we would like to put in place in the Nordics is an accreditation and evaluation system on behalf of the 5 countries so that we could guide the individuals to choose the best solutions for them for the situation that they are in. Because if they are not being pointed toward quality assured solutions, all the data they collect, and we do collect a lot of data from training, from sleeping, from any app that we are having there for fun, then you and I are a wasted resource in the healthcare system, but also in our own situation. So for that reason, we need to have quality assured solutions in place. And to make digital health available for you and I have to be informed that digital health solutions is available for us. And when you and I know that there are solutions for us, it has to be made accessible for us. Not at Google Play or Apple App Store, but perhaps in a different app store or a citizen portal. When they are made available, we have to build trust that they have been looked at from the authority side or from anyone who could assure yourself and I and help us make sure that the solutions are good. And then we have to have a governance model in place, because with digital health, you can't just evaluate them on day 1, because on day 2 or 3 they could have an update, which means that they are no longer trustworthy. So for that reason, you have to have a whole ecosystem to help you and I find good digital solutions that we could use to help out both our own situation, but also the healthcare system. So that was a short introduction to what we are working on in the Nordic Interoperability Project.
Thank you very much, Anders. Really nice. And you touched upon a very key word here at the end, the word trust, which leads us naturally into our next speaker, Deepak Kalra, and the link between big data and trust. Of course, it has to be trusted at a personal level. We can all appreciate that, but once the data goes into those data lakes, how can we trust it? What happens there? For an insight, Deepak, please enlighten us a little bit more. The floor is yours.
Thank you very much. So Lars, thank you for that. Can I just check that you can see my slide okay?
Not yet.
Uh-huh.
No, you need to share your screen, Deepak.
You're quite right. I've done all the other things, but not that. So you can probably see me, can you?
Much better.
Yeah, we've got
okay, jolly good.
Slide.
Righto. Well, thanks very much indeed. Yeah. I'd like to thank you, Lars David, for inviting me to speak, and thank you, audience, for listening. I'd like to convince you why I think your health data is important and why we should be collaborative about making better use of it. So that's really my message. I'd like to start with an example, if I could. I want you to imagine a patient is diagnosed with having a raised blood pressure, doesn't have anything else wrong, and their clinician has got to make a decision about what blood pressure treatment to use if treatment's appropriate. There are different categories of blood pressure treatment that are available to be chosen from. But the question that the clinician will have is which one is most likely to achieve the objective, which is actually to prevent someone from having a heart attack, a stroke, or developing heart failure. So what makes it difficult to make the perfect choice for that? Because all of the drugs are pretty close to each other in terms of the benefit. There are very small differences between them. If you want to study the impact of these drugs, it takes many years for a complication to arise. So normally you would need to study a very large number of patients over a very long period of time in order to determine if any of these is slightly better than the others. Well, I'm pleased to say that 18 months ago, in a very reputable journal, a large study was published, which gave us the answer to that question. And out of those 3 categories, this one came up as marginally, but noticeably superior to the other 2 categories for those patients who are being treated for the first occurrence of their first condition. So not one of Kieran's multi-morbidity, comorbidity patients. What made this research possible? The answer was to look at a very large number of patients across several countries that were able to collaborate, to take those patients' data and look back over several years. So you could look at people who were starting treatment several years ago and say, what's happened to them since they started treatment? This kind of research was undertaken at a scale that would otherwise have required 22,000 conventional clinical trials. It was undertaken in a few months and at not much cost. So that's an example of using data to deliver a result that informs healthcare practice and hopefully results in patients experiencing fewer life-threatening complications. That's not all. There are other ways in which big data has been used already in well-established research to detect cancer risk factors and help people to avoid those risk factors, to help prevent cardiac disease better than we knew how to before, to help determine in this particular study why it was useful to treat older people for leukemia who were sometimes considered too old for treatment. Why is it worth investing in our elderly to treat this condition? And how can we choose the best drug to treat certain respiratory conditions? Now that sounds theoretical, perhaps. These are research findings. But if you turn those findings into healthcare changes, if you change the way you deliver healthcare, you can make a difference. So on this slide, I want you to look at the 4 boxes here. One health system, one very large, complex health system, used its data to determine how it could optimize care better. And I want you to look at these numbers. I want you to look at these statements. These are not nice, pretty attractiveness features. This is not about saving money. This is actually about saving people's lives, saving them really unpleasant complications of treatment, or, for example, pressure ulcers, which can also kill people. This is life-saving use of data. Data is therefore delivering value that we can all gain from. And I would like you to see it in that light. Have we finished learning from data? The answer is no, and I wouldn't have realized before when I made these slides a few days back, we would at this very minute be hungry to better understand about certain COVID vaccinations and blood clots. We're looking for data, looking for evidence all the time. But I also want to draw your attention to the fact that these boxes are very much about treatment, about care of disease. But we increasingly want to turn our attention to prevention and how we can use data to help people to maintain health and avoid getting ill in the first place. And for that, we've got to think holistically. So again, I'd like you to consider that when we're thinking about health data and what we need to bring together, look at the little digital person in the middle. Your digital persona should not be limited to the data in your electronic health record in your hospital or GP environment. We really need data from people, whether it's their individual behavior, what they eat and exercise, but also how they interact with each other socially. There are sensors and wearables that many of you now may be using for lifestyle purposes. We need that data too. We need pollution data. We need transport data. It's the holistic picture that really is what we must now be championing. So yes, we can learn about disease, we can learn about health and healthcare and treatment, but also how to improve health. And I want you to feel a little energized and motivated to care about your data, whether it's in your hands or in the hands of your professionals. We must be insisting as a society that it's used to help us deliver better care, to deliver better prevention, better wellness. But, and here is my kind of conundrum punchline. So this is really where I think we need you to engage in debate. I don't have an answer for this. How do we build trust? Our problem is that we are enshrined at the moment in data protection regulations, which very rightly prioritize the individual and their rights to privacy. We don't want to challenge that. But at the same time, we do know that clinical research brings benefits to society. We know that if we survey patients, they're in favor of the kind of things I've been describing in this talk. So how do we find that balance between protecting the individual and benefiting the individual and society from data? And I think the only way we can really do that is if we engage everyone in that mission. And that means we don't see many of you in the audience who might be patients or healthy people, but not in the healthcare or research world. We need you to be on the inside of the team, helping to co-create the answers, not on the outside, just saying, yes, you may use my data. And I'd like to close just with a message, which is there's an initiative we're part of, proud to be part of, called datasaveslives.eu, which is helping to campaign for public awareness about data uses. Please go to the website, please join our mission. Thank you.
Deepak, that's fantastic. Thank you very much indeed. And again, a rip-roaring ride through a very complex issue, but a very profound messages there, which are extremely relevant to the flow of this meeting. So look, thank you very much. I'll move swiftly on now to take another aspect of digital and health. In this case, we've heard about the use of professionals, use of digital by professionals, the use of big data, interoperability issues. Now I want to turn to Nikolai Holmfarber from Copenhagen to talk to us about customers, patients using digital tools in a particular way. Nikolai.
Thank you. And I'll just try to find my slides. Because of data regulation in my company, the Danish Committee for Health Education, I'm allowed to use Zoom for the first time today because of our GDPR rules. But the whole learning how to share my screen, nobody introduced me to. Just a second.
The green thing at the bottom.
Yeah, I found the bottom. Yeah, it's more the slides I can't figure out. Yeah, here we go.
Tell you if they show, yeah? Yeah. There we go.
Let's see. Okay. Well, there's almost 10% of my time gone by the technical issues. Thank you for inviting me. I'll be giving you a short insight into digital group-based empowerment support during the COVID-19 period, but with the perspective of my very sincere hope that we'll use all the experience and nice interventions developed during the COVID-19 crisis also in the future. So today I'll give you a little bit of theory to support my arguments, and then I'll show a Danish example. I'm working in the area of group-based empowerment support, and in Denmark we've been working with an American developed program, but now it's international since we have more than 35 countries using the program. It's the Chronic Disease Self-Management Group program, and in Denmark we have sort of continued the development of the program into 5 different interventions, and one of them is around anxiety and depression. And I was just following the whole chat during the previous talks, and a lot was about the whole preventive area of dealing with comorbidities and long-term diseases, NCDs, and so forth. And we've been discussing this topic of prevention well, since I started in this business. And actually, one of my insights from the COVID-19 crisis and the activities we've done in Denmark is that digital tools and platforms might have a preventive perspective that is even better than real life. So this is one of my points. But first of all, I would just turn to some a short insight in a model that I'm using a lot myself. I call it the principle of 40-20-40, and it's supposed to show that when you do an intervention, an activity, or in my case, an empowerment intervention, you might fall into the trap of being focused alone on the intervention. This is the blue figure, 100% under during the intervention. And actually, to create the best outcomes, you should be more aware of what happens before the intervention and after the intervention. And my point today is that digital solutions in some sense actually support this principle of 40-20-40 more than face-to-face workshops. And I'll try to give you an example from Denmark. As I said before, we have this anxiety and depression self-management program, which is a the redevelopment of the American CDSMP, chronic disease self-management. And they use it in UK under the name expert patient programs. Before COVID-19, we had an online intervention, but 90% of all participants in Denmark, they were participating in local face-to-face interventions with 2 volunteer peer leaders, a group of 12 to 16 participants from a single municipality, a local area. And the workshop was 7 weeks where you met up 2.5 hours per week and worked with self-management. And the purpose of the workshop was to increase the self-efficacy of participants. Now, during the last year of COVID-19, where it's been almost impossible to do face-to-face intervention, we recreated the intervention in an online setting. And remember the 40-20-40 principle. Back in the old days, we sort of sent out a mail to the participants with a participant book, and we asked them to look in the book and prepare for the intervention. And then we met up for these 7 weeks, and every time I sort of controlled a little bit, nobody really prepared themselves for this, for being part of this intervention before the actual intervention. And then we started off, and after those 7 weeks, you had the possibility of networking, and that was sort of it. Now we've sort of made a blended learning solution, and in this solution we sort of really build on the 40-20-40 principle. So what we did was that we sort of built a platform for individual activities. This is in my drawing, the guy sitting next to the sun looking at the computer in solitary. And this is what you could call classic e-learning. But now comes the 40-20-40 principle, because during these e-learning activities where people actually prepare for meeting up in the group, we ask them different kind of reflection questions. So, and they type in their answers into the system. So when we meet for a 1-hour webinar during the week, we'll continue from the reflection everyone in the group have done themselves, but now we're sort of doing it together in the group. So we sort of recreated some of the very important features of the group interventions, getting people to know each other, getting people to be related and be together in the same room. Now we're doing it in a different way. And listening to all the previous speaks, there was a lot of things you could comment on. One thing is the whole perspective of prevention, but the other one was the value of a handshake. Because at the moment we recruit a lot of participants for our online interventions who would never participate in a face-to-face interventions. To say it in another way, they're not ready to appreciate the value of a handshake yet. So in some sense, regarding mental distress, anxiety, and depression, it seems that the online intervention done in this way actually gets people that we're not able to recruit for face-to-face intervention, that they would actually like to participate in this kind of intervention. So in this perspective, you have a stepping stone intervention towards meeting up in face-to-face in real life. So that's one of the learnings that we've done. But the other learnings is actually that the easy structured access to activities before we meet actually make people prepare. So in regard of this 40-20-40 principle, we spend much more time on preparing the individual activities for participants so that the live webinar that we're doing together will work out in a way where participants feel that they actually co-produce the topics because they themselves have typed in their reflections in advance. And at the same time, we make sure that the content and the process in the live webinars is suited for the unique group of participants in this group, because it is the participants themselves that sort of gave us all the contents for us to work with. And then when we're done with the live webinar, we'll ask people to do action plans to sort of take the reflections from the group intervention back into to their own life. So in this way of doing blended learning of activities back in for yourself, activities in your everyday life, and then a webinar meeting where we meet up, and we in the perspective of distress, anxiety, and depression, we've actually done it very simple. So participants are not on webcam; they are communicating by chats, polls, and other kind of interaction tools on the platform, but they're not on screen, and they're not on microphone as well. And we're discussing whether to open up for the microphones, but we can just see that the percentage of people with social anxiety is quite high compared to face-to-face interventions, and we would not like to scare them off, so to speak. So getting to my sort of punchlines or takeaway messages, the 40-20-40 principle that I've been working with for years actually works quite nicely online, because you can structure and make easy access for the participants in another way than you can when you meet up face to face. Where if I should use myself an example, if I get a letter about an activity I should participate in, I will sort of speedily read the letter and see, okay, what time, what place, and then I'll put it in my agenda, and then I'll wait for the activity. But in this setting, we actually sort of support people in preparing. So they are co-producing the webinars, and in that way make sure that they are suited for the problems in their everyday life. And then this whole early tracing, I mean, we can see in our data now that regarding caregivers, for example, caregivers or significant others for people with NCDs, we usually get them to participate in our workshops when they are in complete chaos, working full-time jobs, being full-time nurses, full-time judges, full-time chauffeurs, and so forth for the significant other. When everything is about to break down, we get them to participate in the physical workshops. In the online workshops, we actually get them to participate before everything breaks down. We see similar data regarding anxiety and depression, that in average on our face-to-face workshops, people have been living with symptoms of anxiety and depression for between 8 to 10 years on average. And now we can see that we're going down to 5 years, 5 to 6 years. And so I wouldn't call it prevention, but I would call it early tracing. And in that way, we can probably help people with tools to turn around a negative circle that can be really bad to something that's easier handled in everyday life. And the last but not least important thing is that we're actually seeing new target groups. People with low literacy, don't have computers or iPads, but they're actually participating through the smartphone. And we have participants that would never participate in any group session that are actually participating in these kind of workshops, because they are not as frightening as participating real face-to-face. So my closing will just be that I see all the disadvantages of digital communication, and all of us are forced to work with how to build relations online and stuff like that. But some things are maybe actually better in an online setting. And I'm not talking about the well-educated. I'm talking the participants in our groups are from all spectrums of in society, from low educated to highly educated. And we have one of our data I can share with you is that one of our workshops for people with anxiety and depression for youngsters between 15 and 25, during the first wave of COVID-19, we did a survey, and it showed that 92% of the participants in that age, they participated in at least five out of the 6 live webinars that we had as part of the intervention. So we had as high participants that if we were doing this face-to-face, which is quite cool, because you actually have to turn on your computer at a certain time. Thank you very much for listening.
Nikolai, thank you very much. Yes, certainly if you get young people to turn up on time or something, atmosphere. I think that's brilliant. Thank you very much indeed. So it's perfect, really, for our last speaker. I'm very pleased to introduce Victoria Betten, whose work I've admired for a very long time. She, for me, is the queen of bottom-up digital in the UK. And Victoria, without further ado, over to you.
Thank you very much for the introduction, David, and really delighted to be here, and what a fantastic range of speakers. I know we're quite pressed for time now, so I will just keep things fairly sort of brief and snappy. I would like to share some final sort of concluding thoughts about the characteristics of a healthy and flourishing digital ecology. I've been thinking about this topic over the past year, ever since COVID struck, actually. So when we entered the first lockdown, I work in digital health, have done for many years. I really thought this is an inflection point for the use of technology within the NHS. And so I started to write a book. I started to write pretty much the first day of lockdown, and I'm still writing now, but I'm about to hand my manuscript over to my publisher in the next couple of weeks. So yeah, unfortunately, all these talks have made me want to completely rewrite my book, but a little bit too late for that to happen. A little bit about me then. My background is in the social sciences. I'm a social worker by qualification, worked in the UK National Health Service for many years. I now work as a consultant, so I also work for a technology company, and I've always been interested, as David says, in human-centered design and bottom-up digital inclusion, digital participation. So yeah, just a little bit about me. And I would just like to briefly talk about non-adoption of technology, which has always fascinated me. And I've done quite a bit of work over the years with Trish Greenhalgh, who is the academic expert in this topic. She produced the NAS framework a few years ago, which talks about all the reasons why technology doesn't get adopted. It's an empirical framework, and it's also draws on many sort of underpinning theoretical frameworks as well, not least sort of complexity and systems theory. And if you're interested in these sorts of issues, I'd very much encourage you to look at that work. I've worked with her on some of the implementation tools that support teams to look at how to put some of the themes of the framework into practice. And I guess what I would like to, oops, sorry, I've just jumped a slide. What I would like to touch on is what I think the problem is that we have at the moment. And I actually think the notion of digital transformation, which we use a lot in the UK, perhaps in other parts of Europe, is actually problematic. It has got very much sullied by a transactional nature. It feels very reductive. We use an industrial metaphor, as we do bizarrely quite broadly within health services, particularly in the UK. It's technocratic, and it deals with things that are complicated, but it doesn't always understand complexity. And when I think about that sort of that notion of digital transformation, I very much think of top-down, supply-driven, clinically led, but not always patient-centered. And I guess what I would like to argue is that we need a paradigm shift. We need to think quite differently about how digital can be used as an enabler of improving health services, public health, and people leading happier and healthier lives, if we're going to make that sort of shift in accelerating some of the changes that we've seen during COVID. And just to pause for a moment on COVID, we've touched on it a few times during the workshop this afternoon. My personal reflection, and like others, I've interviewed lots of people over the last year, we did see a rapid acceleration of very well evidenced technologies such as video consultations, which up until that point have been very much the purview of small pilots. But we haven't seen innovation, I would say, for the most part. We've seen very tactical moves born out of necessity. And I think we've also seen a huge technical debt build up as well. So we need to think very carefully going forward about how we move from the tactical and from the pragmatic to something that is more of a step change. So I'd just like to finish with this slide, which is a very brief synthesis of my thinking. And it brings together a whole load of different approaches, I guess, of what I think the characteristics are of a digital ecology that actually stand us in good stead to really make that step change I think we all want to see. And first and foremost, it needs to be human-centered. It needs to be based around people, and it needs to be recognize the individuality and the differences between us. And I think what we've seen during COVID, that some of the assumptions we've made, for example, around digital inclusion, about the equitable nature of health has been blown apart, and we've actually seen great health inequalities and great digital poverty and digital exclusion. We need to appreciate complexity, and we need to lean into that complexity. And through that, we need to embrace emergence. And that's about the adaptive nature of technology. It needs to adapt to and work within a context. It's used by people, clinicians and patients who have their values, beliefs, sense of identity, their peccadillos. And if we impose something from the top down, it's much less likely to fly. We need to address inequality and pay great attention to equality. I don't think we have any excuse now to not pay attention to inequality. And that, for me, has been one of the great things about COVID, that it has shifted that debate quite substantially, in my view. We need to understand how systems work. We need to take a systems theory approach. And we need to build trust and work through relationships. I have a whole chapter on data and data trust, and we've talked at various points during this webinar about the importance of public trust with data. During COVID, we have not involved patients and the public in the way that we would, I think, have liked to, and we must redress that really urgently, particularly if we're to gain public trust and confidence to use data in the ways that we've discussed today. I think we need to start with assets and build on strengths rather than looking at gaps, which we tend to do a lot in the NHS. Where are the gaps in a system? How can we build on those strengths and assets? It might not be the most efficient way of embedding digital innovation, but it's the most sustainable, in my view, rather than this sort of cookie cutter notion of spread and scale. But whilst we appreciate variety and people's personal differences, we do need shared standards, of course. And so we have a long way to go in terms of interoperability. And it was fascinating to hear the Nordic take on this. And that's absolutely the direction of travel we need to be moving to in the UK. We need to be pragmatic, I think, in harnessing the methods and tools that are out there. We've got patient and public involvement in the UK. We've got quality improvement, but we've also got agile software development practices. We've got human-centered design practices, and we need to find a way of blending those different methods that health services are used to, but actually pulling in methods and tools from elsewhere. And we absolutely need to include the unusual suspects. I've heard people talk of ethicists. We need people with legal backgrounds. We need philosophers. We need artists. If we really want to harness what I think is a very creative endeavor, we need to bring creative and diverse minds. And not only diverse minds in terms of backgrounds and interests, but also in terms of characteristics, in terms of ethnicity, in terms of gender, and so on and so forth as well. And whilst we respond to the present, we do need to have our eye on the horizon and the future. And we don't want to get caught out by just digitizing analog processes. But again, we need to think ambitiously and broadly about the future ahead of us and the horizon and the future that we want to create for ourselves, our families, and for our broader society. So lastly, digital health as an ecology just sits in with a wider ecology. And so we need to think about our social processes, our political processes, and so on that underpin them. I'm going to finish there because I can see David, and I'm sure I'm completely out of time. But thank you so much for your attention, and I look forward to the conversation in the next Zoom. Thank you.
Sorry, thank you very much. We're all out of time, but that was a wonderful presentation. And again, recurring themes of ecologies, systems, the importance of starting the human, and so on. And all your talk particularly underlines for me is the fact that we would love to have long conversations with all of our speakers today, but that was not the plan. What we hope for is for some further seminars later this year where we will have more chance to have really in-depth discussions about these fantastic topics. So thank you very much indeed. And I just want to hand over to my co-conspirator, Lars Munter, for a final word.
Well, it is indeed just a quick final words. Thank you very much, Victoria, and thank you to all of our speakers today. And a wonderful way to finish off my opening remarks about the role of the digital ecosystem in the digital ecology that Victoria talked about, starting off with Jana to begin with, and now finalizing our talk about digital health. Next week, of course, we'll talk about mental health in the workplace. Another important topic, of course, where we link social spheres in various ways. I thank you all for joining us today, and I'll give the floor for a final remark to Jim, and see you next week. Thank you.
Thank you, Lars. Thank you, David. And thank you, panel. This has been extraordinary. I love the little Star Wars figure in the backdrop there, Lars. It was a good symbolic statement of all things digital. You know, it's so amazing how all of us are being challenged by digital technology to completely rethink, reimagine, and redesign every aspect of human endeavor in line with the internet, with Zoom, with all things digital. And when you think that all of public health, education, entertainment, economics, even politics with social media, we are in the process of reinventing what it means to be human through computers, essentially, is what's happening. And it reminds me of what Yuval Harari says in his books, Species and Homo Deus, and 21 thoughts on the 21st century, that the most important transition in the history of humanity is happening right now in our generation as humanity begins to infuse technology and computers with intelligence. Up until this generation, intelligence was purely limited to the biological. And now we're infusing it into machines. And now these machines are taking on a life of their own. And now humanity is being refracted through digital technology in a very profound way, the implications of which, as we're seeing just in the realm of public health, are absolutely profound. And I think, Victoria, your last comments were so poignant, that the challenge is, how do we maintain human empathy, sensitivity, compassion, well-being, holism, love, as we shape-shift ourselves in these fundamental ways. It's an awesome challenge. So Lars and David, this has been a magnificent session today. And I really want to thank you and your entire panel for the breadth with which you've dealt with a very complicated but profoundly consequential issue. So thank you for that. And then next week, as Lars said, we'll conclude this session, although we're happy to report that Lars and David and I met just yesterday, and we're going to convene a further 5 sessions, because I can't think of any domain in the human arena right now that's more important to consider multidimensionally than public health. That is what the pandemic has put front and center for us to consider. So we'll be having more of these sessions over the next several months. And then tomorrow, everyone, we're turning to the issue of the vaccines. And we're going to have an interview with Gary Knoll, who's a scientist, a journalist, has been researching into the vaccinations, has a very alternative point of view. Those of you who've been on Humanity Rising over the last several weeks, we've had a number of people from Johns Hopkins University and the Institute of Health giving us more of the government perspective on the vaccinations. But as we all know, particularly given what's been happening with the AstraZeneca vaccination in Europe, there are many complicating issues. There are many controversies, and we want to bring to people's attention the full spectrum of considerations as we work our way through this quite extraordinary pandemic that up to now, a year in, just won't let us go. And that is something that we need to ponder very deeply. So tomorrow, we're going to have one of the alternative viewpoints on the vaccinations. So thank you, everyone. Lars, David, panel, thank you all very, very much. We welcome everyone to join the after session chat. You can see the link in our chat box here. If any of the panel can join for a few minutes, that would be good so that we can interact more informally. And then we'll see you all again tomorrow. Sorry for the daylight saving time complications today, but it's 8 a.m. Pacific Standard Time in the United States and 4 p.m. CET now in Europe for just this next 2 weeks, and then everything equalizes. Although I must say, on daylight savings times, I can't think of a crazier decision that human beings have made than to start manipulating our time zones in this completely dysfunctional way. But here we are, there it is, and we'll see everybody again tomorrow, same time, same station on Humanity Rising. Bye, everyone. Thank you so much.